Welcome to We in Lewis, a podcast dedicated to celebrating the remarkable, creative, and energetic people who live in Lewis and are helping our community forge a collective soul as appealing as it is unique. These are their stories in their words. They are the We in Lewis. I'm your host, Kevin McGinnis. Our guest today is Dr. Kevin Mallinson, a retired university professor, lecturer, and popular public speaker. He has a PhD in nursing and has worked both in the States and in 7 African countries. Prior to his career in nursing and teaching, Kevin was the first openly gay professional firefighter in the United States. His is a story of courage, toughness, weathering endless homophobic assaults, some of which could easily have proved fatal. Today's episode is made possible by our new partner, Kinetic, with a K, a strategic communications firm that is renowned for creating innovative print and digital media solutions for organizations and nonprofits for more than 25 years. Led by founding partners Sam Shelton and Jeff Fabian, Kinetic is passionate about design and its powerful, positive influence on society. Its clients have included Ritz-Carlton, the Children's Hospital Foundation, and the National Institutes of Health's DASH eating program. Locally, they have worked with the Historic Book Festival, Lewis Line, and the BB Medical Center. For more information about Kinetic, visit kinetikdc.com. This is the second part of our interview with Kevin. In the first, we shared his remarkable story of being the first openly gay firefighter in the United States. If you haven't heard it yet, really you should. And buy his book. It's available at the library, at Browse About Books, at Biblion, and a place called Amazon. It's an amazing story of courage and bravery, and a history that is too often ignored. Kev, welcome back.
Thank you so much, Kevin. Pleasure to be here.
Mark Twain is credited with saying, "The 2 most important days in your life are the day you are born and the day you find out why." Was the day you found out the why the result of a fire on the edge of Old Town?
Yeah, one night we were called to a house fire, residential fire, right in the edge of Old Town by White Street. And it was finishing up. We doused the fire. It was a lot of damage. The house was a total loss. About 2:30 in the morning, my role was at that point to wrap up the hoses, get them back on the truck, and get ready to go back to the station. And I looked over on the curb, and there was the homeowner and his wife and their 2 children. One was an infant, and the other maybe 2 years old, sitting on the curb. Now, they had just lost everything in this house fire, and they couldn't go back in. It was a mess. And so I turned to my captain, and I said, "Captain, what about these people?" And my captain was a good man, but he looked at me and said, "Well, they're not our job. We've done our job. Somebody will help them." And I'm thinking, it's 2:30 in the morning. Who's going to help them? So we went back to the station. When I got off duty in the morning, I went to have breakfast with a friend of mine, Terry Reinhardt. Terry was a nurse out at the hospital, labor and delivery nurse. And I was recounting this story to him, saying I felt really badly that I couldn't do anything for those people because they just lost everything. And Terry very calmly leaned forward and said, "Kevin, you're a nurse. Admit it. Just go out and get a license." And it was at that moment that I realized, yes, I love firefighting, but it is largely buildings that can be replaced with insurance. But people are fascinating. And I'd already been doing enough counseling with people in crisis and people facing HIV/AIDS related issues that I realized I liked the idea of healthcare and keeping people healthy and managing. So that afternoon, I went out to the college and asked the director of the nursing program, "How do you become a registered nurse?" And that's what led me on to, a few months later, beginning in the nursing program at the Florida Keys Community College.
Despite everything you went through, I know it was not an easy decision. I know you loved firefighting. As we said earlier, it was in the genes. But your fellow firefighters did everything possible to encourage you to leave. or kill you or have the union fire you or just get someone to fire you because you were gay. And yet you stayed on.
I loved firefighting. And it wasn't until that moment sitting down with the nurse Terry was the very first moment I ever thought about leaving the department. Up until then, for 4 years, I had been thinking this will be my career. This is what I'm going to do. Now, there were times when I was unfulfilled, but I wasn't at all going to be deterred by the homophobia that I faced in the department. And so I'm more than happy to remind people that I didn't leave the department because I was pushed out. I left the department because I found something that was new and exciting and an interesting challenge that was going to give me a different kind of career.
Can you tell us the story of Kip?
So I started in the fire department in 1981. The first reported cases of AIDS in the United States were in 1982. The first person I never knew who'd been diagnosed with AIDS was Kip Hall. Kip and his partner Dale lived in downtown Key West. They actually lived just a block from the number 2 fire station. They were just an enjoyable couple. When I heard that he had AIDS, I stayed away for weeks, honestly, because I was a bit scared and intimidated. I knew a little bit about this new disease, but not much. And so finally I got up the nerve to call and say I wanted to come over and see him, because I heard he was quite ill. So I arrived that morning and knock on the door, and this very nice woman answers the door. It turns out to be his mother, Kip's mother. And she said, "Oh, please come on in. Kip is out by the pool." So she invites me in. She's got breakfast ready for the two of us. And I went and sat down across from Kip at this small table by the pool. And he looked horrible. He had Kaposi sarcoma, looked like bruises, but tumors, all over his neck, side of his face. His hands were swollen because the tumors were blocking off the lymph return from his extremities. He had lost weight, so his face was actually gaunt, and his hair just looked dry and unkempt, but I guess he wasn't feeling well anyway. I was terrified. And as I sat there talking to him, more and more I kept thinking to myself, Kip is in there. Whatever this body is and how sick he is with this new AIDS thing, Kip's personality is still there. He's still funny and thoughtful and cute. And even though he was quite aware that he would likely die, because so far everybody that had this disease in the United States seemed to be dying. And at one point, his mother comes over and asks if we would like something more, some more coffee or juice or breakfast. And when she does, she puts her hand on Kip's shoulder and neck, right where those tumors were. And then she speaks to him softly and says, "Okay, honey, I'll get it." And she kisses him on the cheek and then gets our plates and takes them into the house to get more coffee. And in that instant, I thought, if a mother could show that much love for her son and not be afraid to touch him, I sure as hell can do this. And so when we finished our conversation, I was leaving, I gave him a big hug. And I'm not kidding. From that moment on, I was never again afraid of getting HIV from somebody by simply being around them or touching them or kissing them, because I educated myself to realize that's not how you get HIV. But I learned that one person's fraction of a second expression of love can be so powerful. And Kip died about 3 months later. And his partner, who we thought didn't have AIDS, he just had diarrhea that was really, really bad, died about a month after him. So indeed, they both had AIDS.
Did this lead you to taking a course?
Yes, I went down. The American Red Cross had just begun to spread information about this disease. And when available, I took a course to become an American Red Cross education volunteer. By 1983, it had been identified as HIV, so we knew there was a virus, and we knew how it was spread. And so the education course got me involved in community groups, talking about how to prevent HIV transmission and how to show compassion for people with HIV.
The fact that you had this experience, you had this realization, but then you took the steps to help others is amazing. And as I believe, it also helped in the fire department because you might have been the only openly gay firefighter, but you were not the only gay firefighter in Key West.
That's correct. And that was something that my Lieutenant Al, who eventually I got to work with full-time, said to me, the second black man ever hired in the department, said in his Bahamian accent, "Don't you think you're the only gay guy in this department? You're the only one that's not married with kids." And I did eventually find out who the others were from different situations around town. And one because he was married and had children, and he had a boyfriend for years. And his boyfriend died of AIDS. And he came right to me just sobbing and saying, "I don't know what to do. I don't know what to do. How can I tell my wife, about this? And I'm so afraid I have it." Well, by this time, 1985, we had a test for HIV. So we could actually get him tested. And I was quite knowledgeable by that time about testing and counseling and everything else. But the extent I did it to is because everybody would know on the island who he was. I called the public health nurse and said, "Can you meet me tonight in the back of the public health building? I will drive through in the dark with my truck, and I'll have this firefighter in the truck with me. You can counsel him, draw his blood and everything else, but nobody will see it. And then we'll come back in 2 weeks and get the test results," because it took 2 weeks. And astoundingly, 2 weeks later, and I knew he was nervous as heck, and I had said to him, "I will go with you to get the results because I know how scary it is." He said, "That's not necessary." He said, "I sat down with my wife last night. I told her everything, and I was so proud of him." And I said, "Really?" I said, "How did she react?" And of course, what his wife said was, "I've always known." And she was supportive, and she went with him to get his test results, which were negative.
Tell us about the use of a scoreboard at the beginning of the AIDS crisis.
Well, in 1983, the Miami Herald had published an article that 500 Americans had now died of this new disease called AIDS. So it was fairly unknown by most Americans, but they were terrified of hearing about AIDS. But 500 had died. A year previous, 2 had died. So in 1 year, we went from 2 to 500, and we knew that it was likely going to be many, many more people. So I heard this, read the article on my day off. When I went into the firehouse the next day, the firemen had cut out the article from the newspaper and put it up on the bulletin board. And then they had created a sports-like scoreboard in which they wrote, "AIDS 500, faggots nothing." I was overwhelmed with grief and anger at that point. 3 of my friends had died of this disease already. And I went to my captain and said, "It's all right for them to call me faggot and pansy and queer and whatever they want and to harass me. But this kind of thing is over the top. Those were people I knew that died." And my captain looked me in the eye and said, "Well, they didn't die of cancer." So I was getting absolutely no sense of compassion. And as far as they were concerned, all gay men should just die.
After you left, how many other openly gay firemen have there been in Key West?
Let's see. I left 40 years ago. Not one. I am the only openly gay professional firefighter Key West has ever had. They've never again had another man who was open.
You got your certificate of nursing, and you were able to go into a community that was excited you were there. What was your first job in nursing?
Well, my first job in nursing was in the emergency room, so it wasn't an AIDS-related, particularly setting. But yes, I had my license. I was a registered nurse. Immediately started working on my baccalaureate part-time through the University of Miami. But I started in the emergency room, which I thoroughly enjoyed, and I was very good in an emergency. So they were thrilled to have me there. I was cool, calm, and collected. Within a few months, I was moved to the ICU because they were looking to have nurses who could manage complex, multiple issues quickly. And I showed my skill set in the emergency room, so I moved to the ICU. By this time, we were having more and more people coming in with end-stage AIDS, as we used to call it. And I was becoming quite knowledgeable about the infections and the course of disease. So I became an asset there because I was sort of the AIDS expert, if you will, among the nurses. And we had 2 doctors at the hospital that were very knowledgeable.
Was it kind of a shock to be working in an environment where they consider you an expert and were glad you were there versus a workforce that seemed to be hell-bent on getting rid of you?
Well, there were several things that happened that I thought were funny. One is I went from working with all men for years to working with virtually all women in the nursing profession rather rapidly, and adapted to that quickly. But I also saw the funny side of male-female relations. I was a brand new nurse. I ran one day with the emergency cart because someone's heart had stopped. And the other nurses, with years of experience, the other nurses said, "Oh, good, Kevin's here." And I thought, the only thing I'm bringing to this is I'm male. I mean, otherwise, I have like 2.5 months of nursing experience. So that was sort of funny, but I think my personality is that when I do something, I completely do it. I jump into it. And so if I ran into something in the ICU like malignant hypertension, which you rarely see, I didn't know anything about it, it's life-threatening, I went home and read up on it. And next time I see malignant hypertension, I'm going to know what to do. And what I found is not all people are like that. But that is my personality, is to learn as much as you can and be ready for the next time.
And thank God for that. Did you find that a hospital, kind of like a firehouse, has a hierarchy?
Oh, it has a hierarchy, that's for sure. I'll give you a good example of who I am is you've gotten a sense of my assertiveness. We now had a test for HIV. And so you had to get consent from someone before you tested their blood for HIV. So this is 1986. I'm in the ICU. Patient comes back from surgery. I'm going through the chart to learn as much as I can for the next few days of recovery and see that he's been tested for HIV. And I look through the chart and I find no consent form. So when the surgeon came in, I said, "Hey, Mike, I don't find they hated it when I called the doctor Mike, but they called me Kevin, so I called him Mike. Hey, Mike, I don't see a consent form in here." And he goes, "Oh, yeah. Well, I just needed to know if he had HIV." And I said, "That's not what I'm saying. The law says you have to have a consent form signed in order to." And he said, "Well, he was, already had anesthesia, so I couldn't." I said, "You could have asked his wife to sign for it." So we had this discussion, which he didn't like being talked to by a brand new nurse. I've been a nurse a whole year. So I explained to him that the law explicitly says this. So then a few months later, in comes a man. He tests him for HIV without his consent. And so I approached him again and said, "Mike, you need to get a consent signed for this. And he goes, well, that's just too much bother. And I said, well, I'm sorry it's too much bother, but you can't keep doing this. This is uncalled for. And he says, I'll do whatever the hell I want to do. So I went to my boss, who was a gay man, and said, Chuck, this is the situation. I'm going to write a letter to the medical board of the hospital, not of the state, but the medical board, to bring him in line. Well, nobody knew it, but my boss, Chuck, had HIV, as did his partner. I was the only one who knew that. And so my boss looks at me and says, do you really want to take this on? And I said, yes, I do. Somebody has to do this. And so I took him before the medical committee and had to show up and give my case. And they censured him and said, don't do this again. So I learned right away, speak up when you're right, and you have you have the law, you have the ethics, you have the moral right to do this. Make sure you defend people and advocate for them.
Good advice in so many different forms. For nearly 40 years, your professional nursing career is taking you to the middle of some of the toughest health crises of our times. As I think we've seen and we've just heard, while others might be inclined to step back, you're consistently stepping forward. Why is that?
Honestly, Kevin, I learned right from the very beginning of the epidemic, the HIV epidemic, that real people die of AIDS. It's not some faceless homosexual out there who dies of AIDS. America eventually learned that. But for me, right from day one, it were people in my neighborhood, my friends, coworkers that had died of AIDS. And so I was dedicated to making sure that people with HIV got the very best care they possibly could. And that meant standing up and advocating, because by and large, people weren't doing it. People would continually say, we don't know enough. We don't know enough. Well, you don't know it because you haven't read it. That information is out there. Go read and find out what the scientists are already saying. And don't be afraid of AIDS. Just know how to protect yourself from getting HIV, particularly as an ICU nurse. You get exposures to all different kinds of things. But I learned that if I don't advocate, who will? If I don't stand up, who will?
I get the impression that your colleagues often turn to you when there is an AIDS case or there are issues involving AIDS. Were you happy with that sort of view of yourself and the orientation? So you might be focusing more on that issue as opposed to others?
I was very happy with that. I very quickly developed two types of expertise. One was in HIV and AIDS itself and all the infections that go along with it. I understood the viral life cycle and those things. And when I interacted particularly with colleagues, it was often in a teaching way. And so by 1987, I was the HIV educator for the hospital. So I enjoyed that role. I had my baccalaureate degree by this time and really enjoyed teaching doctors, nurses, radiology techs, everybody, because there was a law that said they had to learn about HIV. The other expertise that I developed along the way was end-of-life care, not just around AIDS, but around ALS, cancer, automobile accidents. I mean, for whatever reason, someone was close to death. I had done a lot of research and attended a lot of conferences on how do you do good palliative care? How do you manage pain and anxiety? Which eventually led to me becoming a grief and bereavement specialist more than anything. But as a clinical nurse, they would often ask me questions. I think my patient's dying. What could we do to make them more comfortable? And that included physicians, because it's not surprising probably to a lot of people. Physicians are good at fighting disease or cutting it out and that. They're not so good at dealing with people who are about to die. That's when they sort of want to walk away because they sort of lost the war, if you will, or they lost the battle. So I didn't mind at all that that other nurses would ask for support. I had become a member of the Nurses and AIDS Care Organization in the United States, and then was voted to the National Board in 1981. So as part of that role and working at the Johns Hopkins Hospital, I was testifying before state legislatures. I was working with policymakers on how to rewrite policy to be more supportive of people with HIV or at risk for HIV.
You've served on national committees and advisory boards, conducted research, published numerous articles, and you shared in the involvement in the development of scholarly work on 5 continents. You were a consultant. You were for the U.S. Surgeon General and several ministers of health in Africa. What prepared you for such diverse responsibilities and opportunities?
It's funny to say this, the fire department. It really did. I mean, my years in the fire department where I had to face, to be confronted on a daily basis with attacks, I could very quickly decide, is this just a ridiculous homophobic attack, or does this guy really have a concern that needs to be answered? So as I got into nursing, I became much, much more scientific and much more attentive to detail. Not like a lawyer, but I would always be questioning what's behind this and what does the moral code say? What does an ethical code for nurses say? What does the law say? I would read all that so that I could help make decisions about the kind of care I was providing, but also to advocate. And sometimes it was a total surprise that I was sitting at this table helping to make these decisions. You know, a good example was the Surgeon General. When I was working on my PhD, I decided to do a side project. Most people don't do that in their PhD. But I was at Johns Hopkins, and I'd been working on the AIDS unit there for a number of years before my doctoral studies. And I knew that a lot of deaf people had come in with AIDS and died. And in that, I was an interpreter for the deaf in a previous life. And so I was able to communicate with the patients, with their loved ones, with their families. And I thought, man, far too many deaf people are coming in with AIDS. What the heck is going on? Well, there was no research at all about the deaf community. So I got a small grant from Hopkins to go out and interview deaf gay men about their experiences. What did they know about this disease, HIV/AIDS? I ended up publishing and presenting at Hopkins on that just before I finished my PhD. And nobody had ever heard about the deaf community, but I could explain a lot. But I published an article. And so I'm sitting at my desk one day working on my dissertation, and the phone rings, and it's someone asking for Dr. Mallinson. And I said, well, I'm not doctor yet, but I'm going to be soon. And he said, well, did you write an article about deaf men and AIDS? And I said, yes, I did. And he says, well, I'm calling from the Surgeon General's office in Washington, D.C. And I thought, oh, yeah, bull. Why would the Surgeon General be calling me? So I laughed about it, and he goes, no, seriously, my name's Christopher Bates, and I represent David Satcher, and Dr. Satcher is the Surgeon General of the United States, and we were wondering if you could be in Washington, D.C. next week. They named the day and the time, and I said, well, I live in Washington, D.C. and commute to Baltimore, so yeah, sure, I can be there. And he said, we want to talk to you about this. So I end up going there the next week, and there's a bunch of deaf people waiting in the conference room, and I come in, I introduce myself, and then the Surgeon General comes in with Mr. Bates. And the Surgeon General wants to know what's going on with HIV in the deaf and hard of hearing community in the United States. And he had pulled in deaf advocates, so people from New York, Chicago, San Francisco who are deaf, and they're helping deaf people with AIDS to get health care and housing and food and all the other things. To use a pun, he got an earful that there really is nothing out there. And What this led to then is in 2001, we had a national forum on HIV/AIDS and deaf and hard of hearing communities, and I was the opening speaker. And I'm thinking, I'm introducing the Surgeon General of the United States after I give my talk. But again, it was my sense of humor and my attention to detail. I'll very briefly tell you how I opened my talk. I was opening the conference with hundreds of deaf people in the audience and as Surgeon General. And I said, I went through the literature and I pulled up all the articles on deaf people and asthma. Oh, there were none. Deaf people and cancer. No, there were none. Deaf people and diabetes. There were none. Deaf people and HIV/AIDS. One. Oh, that's right. I wrote that article. And they all laughed. And I said, to give you an idea, I looked up Latinas, teenage Latinas, and HIV/AIDS. 47,600 and something articles by that time. Well, deaf people know that they have a culture. They have a language and a culture that is different than those of us who are hearing people. And that it's crucial to how they seek healthcare and how they understand healthcare. So that was the opening. And I'll say David Satcher was a fabulous, fabulous Surgeon General.
Now, you've stressed on several occasions that sign language is a language.
It is.
What would happen if we treated sign language as an alternative to English or French?
Oh, wouldn't that be great? Very briefly, I can tell you of my years in universities. The foreign language departments do not want American Sign Language because they don't see it as foreign. And other departments don't want it because it's not English. So it gets lost all the time in academic circles. A good friend of mine was the original person, Marilyn Volker in Miami, who taught sign language to infants and their parents. And it turns out that an infant can communicate hunger and pain and discomfort 6 months before they can actually speak. So the brain is already working, but if you teach them sign language, they can use it.
What brought you to George Mason?
Wow, George Mason was the last 8 years of my career. I had been living in Africa for a year. After doing years of research and other activities in Southern Africa, I applied for a Fulbright scholarship. And I was a professor in St. Louis at the Barnes-Jewish Hospital System's Goldfarb School of Nursing. And I took a year to live in Africa and be a professor there in the Kingdom of Swaziland, which is now called the Kingdom of Eswatini. And while I was in Africa for the year, my dean back in St. Louis changed. We got a new dean. I'm the first to say that he was an ass. I was thousands of miles away, and I thought, what a jerk this guy is, for any number of reasons. But in that year, 14 of my academic colleagues quit and left the School of Nursing. And I realized I'm not going back to St. Louis. This is not where I want to spend my time. So my husband had been online in Washington, D.C., and he emailed me and said, George Mason University is looking for a professor. So I applied and did a 6-hour Skype call from Africa to apply for the job and got it. So I ended up returning from my Fulbright after the year and going directly to George Mason University and then spent my next 8 years there. I was the director of the PhD program for many years.
What were you studying in Africa?
In Africa, I wasn't studying. I was researching for the Fulbright. But let me back up a little bit. The reason I got to Africa is I had done some work in Brazil. I was down there 5 times over the years to help the School of Nursing and physicians deal with HIV/AIDS better. And so one day I'm in Washington and the phone rings, and it was a nurse friend of mine She had a PhD, and she was doing work in Africa and asked me if I would go there with her for 3 weeks, if I could get off from work, to go for 3 weeks and help her out with a program. And I said, well, where are you going? And she says, to Dar es Salaam. So like most Americans, I said, where? And she said, oh, that's the capital of Tanzania. And I thought, okay, East Africa, somewhere over there. Yeah, okay. So I did end up going for those 3 weeks and determined that that was really what I was meant to do, was to do HIV work in Africa. So that one led to the next 15 years of going back and forth to Africa, working on nursing capacity building programs, doing grief and loss work with nurses and doctors in Africa. And my research for the Fulbright was on a clinic completely run by nurses, serving 11,000 people at risk for HIV or having HIV and tuberculosis, completely run by nurses who have baccalaureate degrees. And they were extraordinarily successful. So I was very lucky. I was often in the right place at the right time, but I had the right attitude as well. And I think that helped me to really make a difference.
So as part of your work there, you were both doing research, but at the same time, you were also helping develop local programming, if
That's
you will.
correct.
What are some of the lessons you take away from those who want to create a program for a community that you are not a part of?
Well, whether it's the deaf community, whether it's the Brazilian community that I worked with, or many African cultures I worked with, shut up and listen. Now, you should ask good questions. So when I very first went to Africa with my own program, I did not know the Zulu community. So I got a bunch of Zulu nurses together because they were going to be what I was going to spend my money on. I had a grant from the federal government. And I asked them what were the problems and what did they need to solve those problems. I didn't tell them what their problems were. They told me. So they said HIV care is very complex and blah, blah, blah. Then I asked them what did they need to solve their problems. And then I asked them, if I come with a program to help you do this, what should I not do? And that was the most important question. They all looked at me with a strange look in their face, and I said, I'm sure Americans have come before and done really stupid things. And they all laugh and shake their head. And I said, what should I not do? Well, they said everything from do not bring big reference books because we're never going to use them. They just hold the door open. Don't bring us equipment that will break down in 3 months and we can't find someone to fix it or replace it. So we hang our shirts on it, those sorts of things. But it was also simple things like, when I wake up in the morning, I'm in a village. And I have to get my children and my husband all set before I get into a combi, a vehicle, and get down to the hospital. And then at nighttime, I need to get back to the village. I need to go to the market, get my stuff, and climb up the hillside back to my village. So make sure you don't start a program till 9 o'clock in the morning and finish a program by 3 o'clock in the afternoon. You Americans seem to like this 8 to 5 thing, but we can't live with that. So I listened to all of that. One of the most important things was we speak English, but we don't speak it all day, and we don't speak it anywhere near as fast as you do. So don't bring people here to teach us that are going to talk incessantly for 2 or 3 hours without a break. So I listened. I took copious notes. And when I developed my program, which the federal government wasn't totally sold on because I might not accomplish everything in 3 years like I said I was going to do. Well, guys, I'd rather do it right than do it fast. Their other complaint was that Americans only focused on the 2 weeks when they were free from their university to come, whether it was a good time for us or not. So I developed a program that was very, very flexible. And I sent 52 nurses to Africa over the years. And they had a rule that they could speak for 30 minutes at a good pace, at a nice cadence with simple words. Don't use all this phrases that Americans love to use. And after 30 minutes, you stop and give the nurses an exercise to do where they can speak in isiZulu, or they can speak in Sesotho or Siswati for 30 minutes or 40 minutes, and then report back in English. Because they all know English, but that isn't what they speak day to day. That's why I was successful, is I paid attention to the culture. I tried to adapt as much as I could, and I spent a lot of time there. One of the best lines I ever heard someone say was, trust has a half-life of 6 months. So if you've been gone for a year and now you're coming back to this country, they're going to say, who the hell are you? But if you show up, and I did show up generally every 4 to 5 months, I was forever in their face. They saw me in the hospital. They saw me in the Ministry of Health's offices. And so they trusted me because I continued to come back.
Did you find in some of the countries you worked, if the better you understood their language, the more successful you could be?
Language was crucial. And I'll be honest, the only languages I'm fluent in is English and American Sign Language. My Spanish, I can get bread and I can find a place to sleep. But other than that, so when I got to Zululand in South Africa, learning isiZulu would just be an impossibility in 3 years. But I was also working in Lesotho and Swaziland, which have different languages. So rather than trying to learn their language, I focused on their names and how to pronounce the places I needed to be. And eventually I learned a lot of other phrases and greetings and things that were important. But to give you an idea, all 3 languages are click languages. So you get words like "msil," that's a click, "msil," that's someone's name, or "wading." Wading is the name of a clinic. So if it starts with a Q, it's going to be but if it starts with an X, it's going to be If it starts with an NC, it's going to be So I learned all these clicks. The X is really difficult, but I learned all the clicks. And so when I was, for the first time, talking to the Minister of Health in Swaziland, and he says, have you seen much of the country? And I said, well, over the weekend, I drove down to Mhlanga and picked up, and he said, you went where? And I said, Mhlanga. He said, you said that correctly. And I said, yes. And he says, Americans never even try. So I found just learning slight things. And there were complex names that Americans would never even try, but I learned skills on how to do it. So I worked with a woman who was Mobile. Mobile's last name was Sithutlanganyane. Well, that took some exercises and learning how to say that. But when I went in and said, Sister Sithutlanganyane, it's such a pleasure to see you today, that just built all kinds of strength and relationship. But it showed that I had the respect for their names. Do you know what Americans do? They'll say to a nurse, I'm sorry, I can't say your name. Can I call you Christine?
Oh.
I actually heard people say that. Or, I'm only here for 10 days, so we have to make this quick. I would never, ever say something like that. So you had to learn what is important to this culture and respect them. But at the same time, and we're talking about earlier about some of the issues of being gay. Well, I'm openly gay and I'm working in an all-Christian country in Swaziland. And our U.S. ambassador asked me one time, do the Swazis know that you're gay? And I said, well, not all of them. There's like 1.2 billion. I said, but at the hospital and university, sure, they've all met my husband. And she goes, wow, why do you do that? And I said, because I'm married. And she said, no, I'm just, it's not part of their culture. And I had a very clear philosophy that, yes, I'm there to learn about their culture, but they're welcoming in an American, which means they have to learn about my culture. And yes, you don't allow marriage here in Swaziland between two men, but my country does now. So it was respectful to say, you have to learn as well as I have to learn, but let's do this together. And let's move and focus on what is really important, which is the health and well-being of the Swazi people. When I came back to the United States, it was interesting that the other programs would put up statistics, and how successful they were. I approached it completely differently, which won't surprise you. I told stories. I said, here's a young man, and Sandile lives in this part of Zululand, and I'd show the pictures and say, what my program did was this. And it put into context everything that we had been doing in that country succinctly. And so in a sense, I was talking statistics, but not really. I was telling a story and how it actually plays out. I don't think our government officials were ever used to seeing that kind of presentation before. It was almost like a storytelling. But by the end of it, I explained how I used the $3.5 million over those years and what successes we'd had.
Is part of your challenge in explaining what you're doing in Africa the lack of information that many here in the United States have about the continent?
Oh, absolutely. I'm astounded at how much Americans and professionals, doctors, nurses, others, how little they know about Africa. So I had presented at Johns Hopkins University at one time. Going back, I give lectures, and was talking about my work in South Africa, Lesotho, and Swaziland. And one of the PhDs raises her hand and says, I'm sorry, Kevin, do you speak African? And I sort of bit my lip a little bit.
Was there a groan from the audience?
There was a little bit of a groan. And I said, it's interesting. In Zambia, just one of the 53 countries in Africa, Zambia has 71 distinct languages. So, no, it really isn't possible to learn all of those languages. I said, and as I answered your question earlier, I've learned how to say phrases in each of the countries and pronounce people's names. But you sort of think they don't even know there's 53 countries on that continent. They don't realize South Africa is nearly the size of the United States, that it is one big country that's extraordinarily diverse.
Was the country's reaction to COVID reminiscent or fundamentally different to the country's initial reaction to AIDS?
Yes. It was initially fundamentally similar in that many people did not believe what was coming out, what the science was showing, because they were getting mixed messages or they were only listening to half of the messages. So there was a lot of confusion, a lot of fear, but it was a very, very different pandemic than HIV. I would say that people in America didn't really get scared about AIDS until after Rock Hudson died. So we're well into the late 80s, and by that time, thousands of people had already died. Thousands of gay men had died. And so most heterosexual people who weren't involved in the LGBT community at all, or didn't know that their family members were gay, were living in bliss. I mean, they were ignorant, and they said, well, that will never come here. So AIDS was very different. It went on for a number of years before people suddenly said, oh my goodness, this seems to be everywhere. As a nurse, I was at the bedside with parents who were telling me that they learned yesterday that their son was gay, and at the same time learning he had AIDS and he was dying. So it was a hard learning for a lot of people to have to go through that. And when COVID hit, the shutdown happened very, very rapidly. And it was, people were thinking of it much more like an infectious, which it was, airborne disease that could easily be gotten from coughing, sneezing, shaking hands with people and this, that. And they did go overboard and clean their cereal boxes and those sorts of things. But it was a very different response. It moved much, much more quickly. and really attacked everybody in the country immediately. Everything from newborn babies to very old people, black, white, it didn't matter. COVID was everywhere. So in that sense, it was a very different pandemic. COVID was awful. We lost more than 1 million Americans. What's similar to the AIDS epidemic is a lot of America would say, oh, did we really lose that many people? There is such an apathy towards people who died, as if it's just past. It's just part of life now, is that people just, 1 million Americans just die of something. And that's sad.
Your whole career has involved death.
Mm-hmm.
You saw it at the fire department. You've seen it in your nursing career. How do you, I'm not quite sure I know how to say this correctly, but how do you deal with so much death that it just doesn't overwhelm you?
Well, I will say that in the AIDS epidemic, when I was a firefighter and then when I was a nurse for the first number of years, it wasn't just watching people in the hospital die. I would come home and my neighbors were dying. I lost 4 romantic partners to AIDS over the years before I met my husband. Lost dozens and dozens of friends. Part of the way I look at death is it's part of life. So far, no one's made it out alive, right? We love to deny that. We like to think we're going to be like this forever and ever and ever. We're not. We're all going to die. And once you really have that set in your mind, then you realize you should enjoy every day. You should enjoy the people that are around you. You should do what you can to make anything better than the way you found it. And I think that's been a big part of my life. My husband and I have started a nursing scholarship. We've endowed a scholarship so that some of the funds that we've made over the years can go towards making sure that people can go to nursing school and can pay their bills and whatever. So helping the next generation. We've adopted a son from Africa and put him through 4 years of college at George Mason University, and he's now working on his MBA, Master's in Business Administration, in Johannesburg, South Africa. So he and his wife and child have got a life ahead of them, and I don't have that many more years ahead of me. So I want to make sure that he and his family are going to be set, that they're going to have a career and be able to go on. As a nursing student, I helped deliver a baby. I cried when that baby came out. It was one of the most extraordinary things you've ever seen in your life. And the first time I was with a dying person and he died in front of me, it was one of the most extraordinary things I've ever seen. So nurses have that benefit of being at the beginning of life and at the end of life. And it really gives you a good appreciation for don't waste your time in the in-between. Do whatever you can, whenever you can, because that's what life should be about.
You seem to be able to understand others' perspectives as readily as most of us understand our own. How did you learn to do this?
That's a good question, Kevin. I think that I've always had an insatiable curiosity, and I've always appreciated diversity. So when I meet people whose culture I'm not familiar with, I'm not embarrassed to ask questions. I try to be respectful. I don't want to, use people for their knowledge. But I worked with the PhD program that I was the director of. We had many students who were Muslims from Saudi Arabia, Oman, Turkey. I only knew superficial things about their religious beliefs and prayer requirements and other kinds of things. But I was able to ask them to explain things to me, or how can I best make this work for you? To me, it's not just making their life comfortable, it's teaching me more. To the point where 2 of my PhD students from Oman, the Sultanate of Oman, invited me to Oman for 9 days to meet with the Minister of Health there and talk about nursing in their country and whatever. And I'm thinking, they're inviting an openly gay man to a Muslim country. So when I asked them, will this be a problem? They laughed and they said, oh, no. In Oman, it's no problem at all. I mean, if you see two men kissing, the police officer will say, take that home, boys. Take that to your home. So you learn that, as a friend of mine used to say, I'm Jewish, but I'm not that Jewish. So you learn to understand aspects of somebody's culture or religion or perspective, but not stereotype them according to that. And that distinction has always fascinated me. So when many of the Africans found out that I was married to another man, they already knew me pretty well, but they'd met my husband, and it was easier for them. And then some nurses would pull me aside in Africa and say, I think my brother is like you. And I would say, he's tall?
When did you first meet your husband, Bob?
Oh, I met him almost 33 years ago now in Baltimore. And we just had our 32nd anniversary. And, how lucky is that? How many people get to actually not only live with someone that long, but still like them? I'm very lucky. I have a husband who's been had his own career, but been very supportive of mine, despite the fact that I left the country like 36 times over the years.
What led you to move here?
To move to Lewis? Bob and I bought a house here in downtown Lewis 29 years ago. It was the second house. It was here for our weekends and vacations. We came down almost every weekend for many, many years. And we just love the historic district, and having a house here. We've known our neighbors for, decades now. So when we retired, we decided this was the place to retire to, and sold our house in Washington, D.C. and moved down permanently 3 years ago. I guess it's coming up on 4.
Kev, I have to ask, have you modified your hobbies at all, or are you still primarily skydiving, scuba diving, and bungee jumping?
No, Kevin, you're looking at a man who's almost 70 years old. I would like to say I still do all those things, but I don't. I would say physically I'm getting older. So, no, I don't quite do those athletic things any longer. I still do some limited hiking. We travel a lot, and so we like to see other cities, and we like to see native areas. So we do some hiking. We did some river rafting just a couple of years ago. But I'd say about 5 years ago, we stopped jumping out of airplanes and doing we were in class 4 and 5 rapids doing rafting. So we used to love that. But no, I focus a lot now on our garden, which I thoroughly enjoy, and then volunteering for the city. I sit currently on the Historic Architectural Review Board, the Historic Preservation Architectural Review Board for the city. So I'm learning, again, a whole new area of how to maintain a historic district in a beautiful city.
Kevin, thank you for being our guest today, for your willingness to share your story with such candor. It has been a remarkable life, and we're lucky to have you a part of our community. Again, how can a listener get a copy of your book, Alarm in the Firehouse?
Alarm in the Firehouse you can get at Browse About Books in Rehoboth. You can get it on Amazon. You'll find a copy at the Biblion bookstore here in Lewis, or for free at the public library on Adams Avenue. And for those who may be interested in hearing me speak and present on the book, I'll be the Lewis Historical Society's speaker for the month of June, on June 12th at the Rollins Center here in Lewis.
Thanks again to our episode partner, Kinetic. That's Kinetik. They do good work for good people and developing courageous and unexpected opportunities for their clients. We should know. They're helping our podcast, and it's been amazing, the difference. And thanks to you for listening. From podcast headquarters here at the bar at Kindle, a wonderful, much appreciated gift from our good friend, Matt DiSabantino. It still amazes us that he would let us record here, although it does raise some serious questions about his judgment. Until next time, this has been We in Lewis, the podcast.